So my disclosure is that I'm not saying that disc replacement is not good, but I'm just only telling why we didn't adopt this so far. So this is not actually a new procedure. The first disc replacement was done in 1950 by the Swedish surgeon, and subsequently it really became popular and it picked off from the late 1980s after the Pro disc actually started becoming very popular. Subsequently, you can see that the Maverick, Flexicore, all these also were discussed quite a lot. And whenever you have a new procedure which is coming in, a new implant, a prosthesis, or a technique, we really need to see what is the natural history and how it is progressing over a period of time. So this is a very recent article, not an old article. It is in Global Spine 2023, just last year. And what it shows is very interesting. The national incidence where in the US where it is the maximum used, you can see that over a period of time there has been a very, very steady decline. And overall, the lumbar disc arthroplasty procedures decreased 82% from 2005 to 2017. And correspondingly, if you look at the cervical disc replacements, it's actually on the increase. So does this tell a story? So we need to be really careful about. Again, there is another article in the Journal of Spine Surgery 2022. All of them are very recent, which just shows that of all the LDRs performed in 2010, that is only 1.2% of them all is there and decreasing to 565 in 2013 and slightly increased to 870 in 2019. So overall utilization of the disc replacement is at a very, very low percent of 0.74, even in the country where there is maximum amount of disc replacement. So that makes you wonder whether this is a part of the Scott's parabola. So Scott's parabola is very famous. That is very common for any new technique that comes into surgery. So it comes as a promising data, then there is a lot of enthusiasm, a lot of implementation that becomes talked about very often and many people start doing it. And at this stage, it is sky high, then there are problems are being reported that are rejected by experts and slowly the usage keeps coming down. So the lumbar disc replacement also seems to be going through the Scott's parabola. So one of the main thing in my mind is a good procedure will have an increase in acceptance worldwide. It's not going to be pocketed to certain countries, in certain hospitals or certain groups or in certain places. And you don't need to promote it. Surgeons will grab good procedures. So on that context, we need to wonder why LDR is decreasing. So here was a good study in 2017, which looked at 613 spine surgeons. Over half of the respondents have performed lumbar disc replacements, but only approximately half of the initial adopters were still currently performing the surgery. And when they asked why, like 54.9% worry about long-term complications and 52. That means half of them worry about the technical challenges of revision. So if you are doing a procedure, and if you need to revise it, and if you think that the revision is very difficult, you are not capable of doing it, or it's going to be life-threatening for the patient, so then you have to really be worried about doing a procedure. So the reasons for the decline is all of these, and we will see one by one. Indication, one of the most important thing here is that there are much lesser indications than contraindications when you talk about lumbar disc replacement. So it is a vague thing like patient aged 18 to 60 with persistent discogenic low back pain. So this is a contentious indication. How do you even define a discogenic low back pain? And everybody in the world are struggling to actually define what is a discogenic low back pain. So when you see the sources of pain in the spine, it's numerous. I mean, it could be from anywhere and everywhere in the spine. And you know that there are many good articles which have shown that it's very difficult to pinpoint your source of pain. And secondly, even provocative discography, when you're doing it, it's not 100% sure. But also there is this Eugene Carrig's Isles Award-winning paper where they have shown that when you're doing discography, you're enhancing and accelerating degeneration even in normal disc. So can you use this as a provocative test? That's true. Third thing is the impact of arthroplasty is still continuing to be very minimal. As we said before, it is only still comprising approximately 2% of all surgeries. Now, So indications are few, indications are not well defined, it's vague. And if you look at the contraindications, there are so many of them. Now, you can see all of this. If there is an inflammatory problem, if there is even a mild facet joint degeneration, if there is osteoporosis, if there is no good end plate, if there is a radiculopathy, if there is a stenosis, if the patient has claudication, and if they have a high pelvic incidence, which actually makes the L5SO disc very, very slanting. So all these things, if you look into it, if in my practice, if you ask me why we are not using, if you leave stenosis, if you leave disc prolapse, if you leave facet joints, lysis, listhesis, inflammatory diseases, dish, any instability, trauma, infection, tumors, everything, then what else is there to operate? I mean, it's just a very small percentage that it is there. It is called the disc degeneration with mechanical back pain. And this is what we have always been taught for a long time, that it is such a contentious indication where the results are often, I mean, it's a toss of a coin. Whatever you do, it's just a toss of a coin. So this area of degeneration with mechanical back pain has been the love. It's the biggest romance between this kind of discs and the industry. So, and there is nothing that we have not done to it. So we have just magnetotherapy, we have put in injections, we have put in enzymes, we have burnt it, we bought IDET, we put chymopapine injection, we try to suck it, we do everything. And you know, there is nothing that we have not done to it. But the real truth is that in this set of back pain, outcomes are no often better than conservative treatment. I mean, this is well proved. And many of these therapies which have come have not stood the test of time, or they have not found universal acceptance. And now we are trying to add a lumbar disc replacement to it. I mean, in selected conditions, in selected herds, it is still good, but it is still a problem. Now, when I say rehab is as good as TDR, is it just a statement or is there a proof? Now you can see this is a well-reported randomized controlled trial, and in the British Medical Journal in 2011. These studies, what they looked at, showed only a marginal improvement. So whenever surgeons put on this thing, there was an improvement. If you look at it carefully, if you read through the small print, it's only a marginal improvement in VAS and ODA score in comparison to comparative treatment. And what is it at the, before they did the randomized trial, they set a point of 10 points, that you have to exceed 10 points of improvement to show that it has really improved. But the mean difference in the ODI was only 6.9 points in the end. So it did not match up to the expectations in these randomized control trials. So that is for indication. The approach, as you know, it's a difficult approach. So you might have heard from morning, many people said, don't do artificial disc replacement if you don't have a vascular surgeon. And our previous speaker also said all vascular surgeons are not capable of even repairing the lumbar artery, because that is not an area where they operate normally. So if you are not having a vascular surgeon who is into your theater within minutes after you have this injury, you are putting yourself into risk of doing this. So that is another big problem over them. The implant also is unforgiving, because you know it entirely depends upon the center of rotation. You could actually place it a little in the front, little behind, or little in the sides, and then you will have a catastrophic failure. So this is what happens. A little in the front, and then you see it's opening much again, and then what you need to do is to actually remove the implant, which is a big surgical risk, or you keep the implant inside and then fuse it, and then this report said that the results was very good after fusion. So then why not have fused it before without putting the lumbar disc replacement is a big question. So you can see here, you have to be, it's a very, very technically challenging procedure. If you do it either on the sides, then it goes all over the place, because the lower lumbar spine is biomechanically very, very challenging. I mean, there is a huge amount of this thing over there. So Marek and Robert Gunsberg, they actually told how difficult, how exacting, or how much demanding the biomechanics is on the lower lumbar spine, and it's very difficult to get it over here. So third point, does a disc replacement maintain mobility all the time? You know, many of these, they actually said the lumbar spine opened up by 3 degrees or 2.5 degrees or 7 degrees or something like that. But does it actually matter quite a lot? Because these discs are supposed to give mobility to the lumbar spine, but they were also very mobile all over the place when you put them. You can see there are many, many places where they are running all around the lumbar spine, and some of these have actually come out also. And these are quite dangerous to normally move because they are just on the pulsating vessels, and they are quite difficult to remove too. Because once they come out, they set up an intense inflammatory reaction, and that's a big problem. So this was attempted. It's all internet pictures. I don't do this. So attempted to put mobility behind this, and you can see it has just come out, and then it had to be do that. So there are lots and lots of articles about how catastrophic it could be when it's there. And Dilip Sengupta, he has actually shown that many of these patients have heterotrophic ossification also. So it's not 100% sure that all of the discs that we are going to put is going to. So last, do you fuse or do you put a disc replacement? And here you can see all the major reviews that are come. This was in 2017. They found that whatever has been reported as a benefit by disc replacement was not over clinically important differences. This is something that we really need to wonder about. When you're talking of doing a major procedure at a higher cost, technically more exacting, with more potential complications and the complications being difficult to take, you need to be sure that what you get for this risk is something, a big benefit which you need, and that has not been really shown, because this meta-analysis also actually showed that they did not properly evaluate adjacent segment and facet joint degeneration, which is a defect, as this is the reason that disc prosthesis was manufactured. So many of these analyses are not actually looking into what actually matters for the patient. And the risk of adverse event and reoperations were similar between the groups for 5-year follow-up. So this is all very important. So again, this is a Cochrane library, which we all know that it assimilates all the data and then puts it. So they concluded saying that the degenerative discs were not beyond the generally accepted clinical important differences. So small differences reported, but not really great. The primary goal of prevention of adjacent level disease and facet joint degeneration by TDR, as noted by the manufacturers and distributors, was not properly assessed and was not a research question at all in most of the reports that were reported. So, we are skiving around the main issue and reporting a few things which doesn't matter to the patient in the end at all. So implant failures are also very common. The latest models might have changed it, but initially there was a lot of polyethylene wire debris, and these would actually cause a lot of biological effects. These debris induce inflammatory reactions, and this could be a big problem for adhesions around the vessels, and in revisions, they can actually mean quite a lot. So you can see here, that's one of the reasons that why that failures led to exponential increase in revision rates, and this is actually in global spine in 2018. And you can see that the revision burden for lumbar disc arthroplasty surgeries in the US, as the usage increased, at every period of time that the usage increased, there was an increase in the revision rates also, and that's a big problem. Finally, this is something that everybody who does TDR speak about, that it prevents adjacent segment degeneration. And this is published in Spine. Degenerative changes associated with negative influence on postoperative outcome parameters, and this, it didn't show any much difference at all. So it all comes to the whole question of, if both are equal on results, on the matters in which it matters to the patient, so why take the big issue? And lastly, you should be looking at what happens if there is a revision required. So you can see that there are many reasons for revision, and when you do a revision, it's actually a very, very complicated thing. Putting in it without a vascular surgeon is a big risk, but if you are going to revise even with the vascular surgeon, it's a very big risk. So that's why it's now contended that if anything fails, it's much better to just fuse it from posterior without attempting to remove the disc. So that is most important over here. So complex scenarios, all these, sorry, I'm going the wrong way. So these are some of the examples that happens over. So in summary, I think the reason why we didn't embrace it very with open arms is that looking at the indications, I didn't think it was a procedure not very much indicated in my practice. Even in the Western literature, there's a very good paper which asks how many surgeries, problems, degenerative problems are actually amenable, and they came out with less than 7% of the people had perfect indications. It requires a different approach with a different set of associated complications. And I'm seriously not worried about the marginal differences and a little bit of radiological findings that you find in most of the reports that are promoting TDRs. And it is an implant that has an equal failure rate with posterior surgeries. But when it fails, the difficult revision is much, much more difficult than when you do from posteriorly. So these are the reasons why Amit gave a topic, why have you not embarrassed, or why I am skeptical about TDR. And I think that these are the reasons that I can summarize. Thank you very much. Thank you.